Hello, and welcome to the Us versus HPV webinar series taking place from January 22nd through January 28th. I'm Shobha Krishnan, founder and president of the Global Initiative Against HPV and Cervical Cancer, and the moderator for today's talks. This webinar is hosted by the American Medical Women's Association, Global Initiative Against HPV and Cervical Cancer, and Indiana University to recognize January as Cervical Cancer Awareness Month. In addition, this webinar is also being hosted to spread awareness about the various diseases caused by the human papillomavirus, or HPV, beyond cervical cancer, and the excellent and effective tools that we currently have to prevent them. The goal of this webinar series is to spread knowledge and encourage and empower you, the audience, to join us in this campaign. You have a number of ways to access this event: live stream, dial-in, and video replay. All webinars are recorded and are free. You can find more information about this series on the IAHC homepage or by Googling Us versus HPV. You can also find us at Facebook, Instagram, and our Twitter handle is #UsVersusHPV. A big thank you to our supporters. Today's topic heading is HPV and cervical cancer, a global perspective. We have 3 speakers, each of whom will speak for approximately 15 minutes. We will then open the floor for questions and answers. You can submit your questions anytime starting now through the Q&A icon that you will find at the bottom of your screen. Selected questions on today's topic will be answered live during this session. All handouts are available through the chat box icon, also seen at the bottom of the screen. A link to them will also be emailed to you after the webinar. Our first speaker for today is Dr. Julie Terode. Dr. Terode is the Director, Special Projects Union for International Cancer Control from Geneva, Switzerland. She's also the chair of the WHO Advocacy and Communications Working Group on the Cervical Cancer Elimination Initiative. Her talk today is on Accelerating Cervical Cancer Elimination, a WHO-led global initiative. Julie?
Carrie, unmute her mic.
Yeah, Julie has to speak now.
For a split second, you got me. You got me. Right.
You're good to go, Julie.
I'm sorry about that. Seems like there was a difficulty with my mic. Can you still hear me?
Yes.
Okay, I'll start again. So thank you, Shobha, and welcome to this second Us versus HPV webinar. It's my great pleasure to share the policy perspective from globally and the exciting opportunity of eliminating cervical cancer. I have no disclosures and no financial conflict of interest. Today, cervical cancer is an avoidable cancer, but when you look at this global map, you can see that the burden is rising. The newest data of GloboCan 2018 show that there are over 500,000 diagnoses every year. And let's just think about that. That means one diagnosis, one woman receives the diagnosis she has cervical cancer every minute of every day in a whole year. And when we look at the incidence rate, it's the first time that that mortality rate has gone over the 300,000 mark. And most of those deaths, as you can see in this density map, occur in low and middle income countries, showing the gross inequity of access to care for this avoidable cancer. we overlap the incidence of HIV, you can see that the high incidence areas for cervical cancer also overlap with the highest burden of HIV. And in fact, it's maybe not known to many that women living with HIV are more likely to be co-infected with HPV and vice versa. This means that they are 4 to 5 times more likely to have the persistent infection that leads to cervical cancer and then get cervical cancer. And they develop cervical cancer at a younger age. WHO has been working in this area for some time and embraces a life course approach to control of this disease. If you look at these graphs, you can see the key interventions follow the infection. So we're first looking at HPV vaccination before the red line starts, before we start to see an increase in HPV infection in the population. And then we start to engage in screening as the pre-cancers start to appear and cancer starts to appear. The idea of screening is to find the pre-cancer before it can start to progress to cancer. And we're encouraging that screening to occur at least once in a lifetime by age 30. And then the opportunity, the third prong, is to really try and find cancers themselves, the cervical cancer, as early as possible. And that's where screening also helps to find cancer when there's an opportunity of surgery and radiotherapy for cure. WHO has global guidelines in this area. There are programmatic, globally agreed indicators. And in fact, the recommendations based on cost effectiveness are there for each of these interventions. So you do have to ask yourself, how come the global mortality map looks so devastating? And it mirrors the incidence map showing the high density of deaths, 9 out of every 10 women dying from cervical cancer in low middle income countries. So it's a great opportunity for us that the Director General of WHO, Dr. Tedros, decided in May at his first World Health Assembly to make an announcement on his personal ambition to eliminate cervical cancer globally. From the perspective of my organization, Union for International Cancer Control, this is the first time that a Director General has made such a bold statement on cancer, and we were more than happy to join forces with UN agencies, other civil society groups to support that call to action. And we were pleased to see members of our government stepping up, ministers of health supporting. The Minister of Health Rwanda made a key address. 12 ministers of health were there at the event making supportive statements. So there is some increasing momentum around the ambition to eliminate cervical cancer. But before we go any further, what does that actually mean? We're talking about eliminating cervical cancer as a public health concern. This term needs to have a clear defined target, and WHO has been working with experts and partner organizations throughout the past few months to develop a clear definition of elimination. And that is now moving towards the idea of reducing the burden of cervical cancer to 4 per 100,000 women per year. I should note that this does need to be confirmed through consultations with member states in 2019, so that may change. But I think for comparison, when we think back to those maps, the highest rates in sub-Saharan Africa have a rate of over 60 per 100,000 women per year. And so you can see the journey that many countries have before them. So let's have a look at the conceptual framework of how this might happen. Currently, if we look at this blue line, the levels of vaccination, screening and treatment that we have in the world is really taking us nowhere. Moving down in that graph is saving lives, and we're pretty much in a flat line. So what we're doing now is not good enough. If we intensify vaccination, that means increasing the coverage to make sure all girls in our communities have access at the right time. Then we see that the curve comes down. We are starting to save lives, and towards the end of this century, we're really getting impact towards that elimination threshold. But interestingly, the modelling shows that if we add screening into that mix, we pull that curve down earlier, we start saving lives earlier, and we can actually achieve elimination in all countries. So that is the ambition. And so the emerging framework and definition is defined here on this slide. And again, it will be subject to consultation, but this is the shape that we're aiming for. We want all countries to get up on that high coverage and that pathway to elimination. So we're asking member states, our governments, to commit to 2030 targets and a vision of a world without cervical cancer. The goal being to push that level of incidence of cervical cancer down to 4 per 100,000 women annually. And we want to do that by driving for 90% coverage of vaccination, 70% coverage of screening, in 2 screens in a lifetime, and of course, follow-up of all positive cases, and putting systems in place to reduce mortality by 30% by 2030. Now, that is an ambitious plan, and that's why we need to get member state support and head of state support. The presidents, prime ministers of our countries need to be behind this. So Dr. Tedros took this mission to the UN General Assembly in September of 2018, and here's a snapshot of him with the First Lady of Niger. What it was important is that government stood up to support Dr. Tedros in this endeavour, and particularly the President of Zambia hosted that event, showing the high-level support and interest to really take this initiative forward. I encourage you to look at the video by UICC in collaboration with Dr. Tedros. He will be releasing a new video on World Cancer Day, so look out for that, and we'll be happy to share that with people on this webinar. So why are all these events in Geneva and New York important? Well, we really need to build political support for elimination. We've been working with the cancer community, the World Cancer Congress, the research and HPV community, the professional societies that engage and manage cervical cancer and women's health, to signal support from the expert communities to take this forward, showing that the time is right. We're looking to civil society now to really engage member states, show that this emerging support is there, and get member states engaged, particularly motivating the WHO leadership. They're being aspirational, and we need to feedback and show them that they're doing the right thing. Heads of state, every single one of your heads of state, your prime minister, your president, your king or queen should be behind this and really driving this. So think about how you can raise the profile and get your head of state to be part of this story on the global stage. And as you saw with that graph, elimination is going to take us several decades. So we need to foster cross-party support and pan-government support to make sure that these services continue and persist to have an impact over the coming years. So how can you help? Well, engage your National Cancer Control Plan committees. Make sure cervical cancer strategies are built in there and aligned with the elimination goals. Share these emerging developments with your governments and the people that can make decisions to take this forward. And give them a sense of the growing engagement and need to get involved. Build your own regional or national coalitions, not only to advocate, but to join forces in 2019 and really push globally and regionally to get the story out there. As I said, press for your head of state, not just your Ministry of Health or your Ministry of Women Affairs. Think about your head of state getting involved, and press for your government to make a national commitment to elimination, making it public. And I was pleased to attend such an event just on the 14th of February in Malaysia, which was well received, massive media pickup. And in fact, today, Kenya's also announced their cervical cancer plans. So I think we're having more countries stepping up and making their plans public, and that's very important. And lastly, join forces with UICC and our other civil society partners to advocate, but also to monitor progress globally. I'm having trouble moving the slide. So how do we engage our communities? This is a story that you can find on the Together for Health website. There's a series of personal stories on engaging with cervical cancer. And this is the story of Christine, who's a professional woman working in Kenya. And she's one of nearly 4,000 women that were diagnosed with cervical cancer every year. And she says that she didn't even know what cervical cancer was until she heard about a women's forum. And that's how she managed to find and get her cervical cancer diagnosed. So how do we change that? Women in high incidence countries often know about cervical cancer and know it's a killer in their community. They see people dying in their families, or their friends, and their communities. So we not only need to transfer knowledge about the disease and the disease burden, we need to think about how we transfer knowledge and understanding that health services can prevent cervical cancer, and that early detection and treatment can be life-saving. And as individuals, we can actually influence that. So we need to build knowledge, but also empower to take action. So I think important when we do that is also think about engaging the whole of community, not just women. It's very often the men in our families that make decisions. Let's get them behind making this positive health choice for our families. We need to engage communities and let's think about the leaders, religious leaders, school leadership, community influencers that can get behind this ambition to eliminate cervical cancer from our world. So how can you get involved? Well, make your coalition and your work of your organization a trusted source of accurate information. This is the first step. Think about information on prevention services, but also think about signs and symptoms and making sure women know where to go to get help, that they can actually take that action step. Finally, I'd just like to encourage you to think about getting involved on World Cancer Day. We have a message pack that you can share, you can use, it's free for use. We have a campaign called I Am, I Will, and we have some ideas on how you can use that campaign to talk about cervical cancer elimination. And we also have a social media guide to add your efforts to that of others and make sure we amplify our voice on the day when the world's media do talk about cancer. So think about joining the campaign, add your activity to our World Cancer Day map, join the social media push, and think about joining our planning team to work in 2019 moving forward and have a great joint effort for 2020. Here's just a taster of some of the things, how you can get involved. There's a poster tool to make your own poster. We have different languages. You can use custom messages or make your own and add them in. And that's a great base to engage your community. Join the social media campaign. But if there is one thing that you do, please think about generating your own I Am, I Will story and sharing that with us. So express your support for global elimination of cervical cancer and share that with the community on World Cancer Day. So thank you. I hand back to you, Shobha, for any questions or the next talk.
Thank you, Ellen. That was very motivating. And that should segue well into my talk. The world could end cervical cancer if it tried. A call to action. Just imagine a world where we have eliminated the very first cancer from the face of this earth, and each and every one of us played a part to make it happen. That would be great, isn't it? Well, the good news is this does not have to be imagination anymore. We can make it a reality with cervical cancer, like Julie mentioned, with the tools that we have on hand today. As we heard, cervical cancer is the only cancer for which we know the cause. Over 90 to 99% of cervical cancers is caused by a virus called the human papillomavirus, or HPV. And because we know what causes it, we are able to target it with the HPV vaccine, which is up to 97% effective in preventing cervical cancers. In addition, we have safe, simple, and inexpensive methods to screen for this cancer, such as the PAP test, HPV DNA test that looks for the DNA of the HPV virus if present. Now, women can even do self-sampling for this test. And there are many more newer tests on the horizon. But in areas such as the rural parts of the developing world, where none of these tests are possible for either economic or logistical reasons? We screen with household vinegar. Yes, household vinegar. And the test is called VIA, or visual inspection with acetic acid. Here, we apply vinegar on the cervix and wait for a minute. If it turns white, it means there are some abnormal cells, and then we treat it at the same visit, if possible, by freezing the abnormal cells with a device called the cryogun, and the method is called cryotherapy. The advantage of this one-stop screen and treat method is that we don't lose women to follow-up. Otherwise, their husbands might say, well, why do you have to get treated when you have no symptoms? And then the mothers-in-law will have to put their 2 cents in, and all this might discourage a woman to come back for treatment. And so it is important, as far as possible, to keep it a one-stop screen and treat program. And this can be performed in makeshift clinics or mobile vans in remote areas of the developing world where cervical cancer rates are the highest. This method is also endorsed by the WHO, or the World Health Organization. And in spite of all these tools we have to prevent cervical cancer, 1 woman between the age of 35 and 60 dies every 2 minutes in this world from this disease. Really sad, isn't it? And we all know what happens when a relatively young woman dies. She leaves behind young families with young children who then spiral down further into poverty and economic despair. Worldwide, there are about 500 to 600,000 cases of cervical cancer that occur on a yearly basis, with about 300,000 women dying from it year after year. Now, if you look at this map closer, you will see that the cervical cancer rates are pretty much low in developed part of the world, such as US, and it's high in developing parts of the world, such as Africa. Why is that? When 60 years ago, cervical cancer was the #1 cancer killer among women in the US. And today, it's not even in the top 10. So something miraculous happened here, right? What is it? It is the introduction of the Pap test, or the Pap smear, which has reduced the incidence of cervical cancer in the US and other developed nations by nearly 75%. So as you can see, this is a disease that is all about access, isn't it? In countries where women have access to screening, the rates are low. And in countries where women have little or no access to screening, the rates are high. In the US, we still have 13,000 cases of cervical cancer per year, with 4,000 deaths occurring from it on an annual basis. Even today, 4 out of 5 women who get cervical cancer in the United States are those who have not had a Pap test in the past 5 years. So ladies, wherever you are, please remember to get screened for cervical cancer. And now, with the combination of the vaccine and screening, we can almost eliminate cervical cancer worldwide. And I really hope that in addition to the vaccine, we are able to introduce self-sampling widely, both in the developing and developed parts of the world, in order to screen hard-to-reach women. That is when we can almost eliminate cervical cancer. Then, what are we waiting for? Time for action, isn't it? How do we start? Where do we start? And who do we talk to help us attain our goals? Well, we can start with healthcare providers, such as doctors, nurses, pharmacists, colleagues. A strong and effective recommendation from you is the main reason why parents decide to vaccinate their children. We have multiple studies from around the world showing that the vaccine is effective in preventing nearly 90% of HPV infections, which cause majority of HPV diseases and cancers in both men and women, and the vaccine is up to 97% effective in preventing cervical cancer. Look at this slide. So HPV causes majority of penile cancers, vulval and vaginal cancers, oropharyngeal or throat cancers. In fact, these numbers in both men and women have gone up, 37,000 in men and 14,000 in women. Men get it more than women. Anal cancers in both men and women. Both these numbers have also gone up. And of course, cervical cancer, which is the most serious consequence of HPV globally. Not to mention all those abnormal pap smears that women get due to HPV, which makes us go to a doctor's office, have multiple visits, multiple procedures, and not to mention the emotional toll that it takes on a woman when she's told she's HPV positive. In addition, look at the number of genital warts in millions in men and in women. And like Dr. Kirchgraber said yesterday, think about this, men. How about if the lesions in the most sensitive parts of your body had to be burnt off? Now that should awaken you, right? And also, HPV causes over 90% of entity called RRP, or recurrent respiratory papillomatosis caused by HPV. And this is where polyps develop in the air passages of babies, children, and adults. And the reason babies get it is because of the transmission of the HPV virus from the mother to the babies. In fact, latest research is also showing that HPV may be a cause for some skin cancers and prostate cancers too. So it makes sense to vaccinate not only girls, but also boys, because HPV causes diseases well beyond cervical cancer, and the vaccine prevents majority of HPV infections. And for parents who might still have questions about vaccinating your children, let me assure you that the vaccine is a safe vaccine, it's an effective vaccine, and it works. It works better than we expected. As we saw, it benefits both boys and girls. And there is an added incentive to vaccinate on time, which is 11 to 12 years of age, because this is the time when children produce the strongest antibody response to the vaccine and get best protection. It is also the time they have least exposure to the virus, because while HPV can be transmitted through non-sexual routes, sexual intercourse is the most common form of transmission. Now, some of you might think, oh, well, in that case, my son or daughter does not need this vaccine this early in life because they are not sexually active. Let me remind you that this is the age when you get your best bang for your buck, because the antibody response is the strongest that lasts for years and years, and the vaccine helps to prevent, not treat HPV. And for those poor parents who are still hesitant, thinking that your child can get the vaccine when older, let me share. I'm also a parent, and that too of a daughter. And as much as we would like to think that we have control over situations, we all know that not everything is in our control, right? Look at the Me Too movement, for example. What if our children did all the right things, but came in contact with someone who might have contracted the virus many, many years ago, didn't know they had it, and transmitted silently to our children, who then might get the disease? The HPV vaccine is one tool that we have to protect our children. And yet, only around 50% of girls and boys are getting the full series of the HPV vaccine in the US, and only 1% of eligible girls worldwide have been vaccinated. So providers, parents, please help us improve the rates of HPV vaccination. Next, who else do you think can help us scale the cervical cancer and HPV prevention programs? Politicians. Look at the cost effectiveness of this vaccine. This is a slightly older slide, but a simplistic and a good way to drive the point, I think. For example, in the US, we spend $7 billion, that's a B, to treat 3 million HPV-related cases in women, and 3 million is not even all the HPV-related cancers and diseases in women. And for half that amount, that's for about $3.5 billion, we can vaccinate all girls and boys between the ages of 9 to 14. And if we did this, as we saw, we will be preventing majority of HPV-related diseases and cancers in both men and women, and save many, many more millions of lives and dollars. Similarly, with approximately the same amount of dollars, that's about $3.2 billion, we will be able to do much, much more globally. We will be able to vaccinate 160 million girls, each with 2 doses of the vaccine, plus screen and treat 170 million women, avert 5.2 million cases, and 3.7 million deaths from cervical cancer. How is that possible? because Gavi, which is the Global Alliance for Vaccines and Immunization, has specific quotas for eligible countries to procure the HPV vaccine for $4.50 a shot. And this combined with the vinegar test for screening that is inexpensive and the HPV self-sampling test that's available to eligible countries for about $5 a test, we can do a lot more. But the key here is to integrate cervical cancer prevention services with other global health prevention programs, because those global health assisted programs that work with HIV/AIDS, maternal child health, reproductive and women's health have all had great successes. That women who are now surviving those conditions are dying of cervical cancer because there is no organized system for screening. That is why it's important to integrate cervical cancer prevention services with other global health prevention programs to save more lives. And for businesses, look at the CSR. CSR meaning corporate social responsibility and the return on investment. For every $1 invested, returns can be as high as up to $3. So now we can clearly see that cervical cancer prevention is not only a women's health issue, it's a reproductive health issue, a sexual health issue, maternal child health issue, economic issue, and above all, a human rights issue, isn't it? Each and every woman in the developing world deserves to be screened at least once in her lifetime and have access to the HPV vaccine for her children. And it's always worth reminding ourselves that when people anywhere are desperate, people everywhere are at risk, isn't it? And it takes a village for sure. We have to engage men, just not women. We have to engage school leaders, religious leaders, and other movers and shakers in the community. And who else do you think can help us? The younger generation, of course. You have the power to eliminate this cancer. Get the HPV vaccine. Be proactive. Use social media, mobile technology to spread the news about the vaccine and the importance of screening. Be a part of finding our first moonshot for cancer. And finally, a call to the most powerful of voices, celebrities, and above all, our patients. Celebrities, you can help us raise awareness by mobilizing millions of people at a time. And patients, you have the most powerful of voices to save lives by sharing your stories and experiences. In fact, on Monday, January 28th, we have a session where students and patients will be speaking about their involvement and experiences. And we'll finally end the webinar series with a very inspirational and aspirational short film called Lady Ganga. Hope you all get a chance to watch it. So wrapping up, here are some examples to show how much we can do with so little for cervical cancer prevention. These are approximate numbers and require some qualifiers, as they can vary from country to country, of course, but you'll get a pretty good sense. For example, for less than $10, we can vaccinate each child with 2 doses of the HPV vaccine. For around $25 US, we can screen and treat a woman for early disease. For $35, we can screen a mother and vaccinate a child. And for $50,000 to $100,000 a year, we can run a cervical cancer prevention clinic in a rural area of the developing world where we can educate, you see this outdoor education that's happening here, screen with household vinegar or HPV self-sampling, treat, and use modern technology to transmit images to experts to get immediate feedback for management. All this from a rural clinic to manage, maybe approximately 2,500 to 3,000 women per year. That's pretty good, right? For how many cancers can we boast of such successful preventive methods at such little a cost? So if you'd like to get involved, please contact us at info@GIAC, GIAHC.org. Our website is www.giac.org. You can visit us on Facebook, Twitter, Instagram, and our Twitter hashtag is #UsVersusHPV. Thank you. Our final speaker for today is Dr. Ellen Baker. Dr. Baker is in the Department of Gynecologic Oncology and Reproductive Medicine, University of Texas, MD Anderson Cancer Center, Houston, Texas. Dr. Baker is also a retired NASA astronaut and served in the medical branch of NASA. Ellen?
Okay, thank you so much for the introduction. And I'm going to talk today about a tool that we've been using at MD Anderson to help improve cervical cancer screening, both here in the U.S. and also around the world. I have no disclosures and no financial conflict of interest. We are using something called Project Echo, which you may or may not have heard of. It is a very simple model that was founded by Sanjeev Arora from the University of New Mexico to help what he calls demonopolize knowledge that generally resides in academic medical centers and share it with providers around the world in rural and underserved areas so that patients get good care close to home and don't have to be referred to centralized referral centers. And what brought him to Project Echo was hepatitis C in New Mexico. There was really an epidemic of hepatitis C. About 30,000 people in the state were infected. 15 years ago, it was a very difficult disease to treat. And in fact, less than 5% of people with this infection had been treated. The wait time in his clinic in Albuquerque was eight months. There were only 2 places in the state that treated this disease, and no primary care physicians were providing treatment. So he traveled around the state and engaged with primary care providers from rural clinics and actually some from prisons. And he started a telementoring program with the goal of providing support to people in rural and isolated areas that didn't have access to specialty consultants. He trained physicians and mid-level providers, physician assistants, nurses, etc., in HCV treatment. He conducted weekly clinics with his multidisciplinary team at the University of New Mexico. He initiated case-based guidance, that is, partners out in the community presented cases, and he and his colleagues at the university provided guidance and practice. And he collected data and monitored outcomes and looked at the cost and effectiveness. After 3 years, he studied, he did a prospective study, and he compared 407 patients treated in the community through the Project Echo model and compared them with patients treated at the university, and essentially there was no difference in the hepatitis C cure rates. And that got the Project Echo ball rolling. And so Project Echo has been applied now to many, many different disease types and many, many different sorts of scenarios. It's a video conference, but to call it Echo, you have to pay attention to the 4 pillars or the 4 guiding principles of Echo, and that is to use technology. And by that, it's video conferences to leverage scarce resources. Through this, share best practices to reduce disparities, use case-based learning to master complexity and monitor your outcomes. Again, the goals were to demonopolize knowledge and to increase capacity in regions that did not have this capacity previously. That is, to be able to provide more specialty care in areas where there were not specialists. It is not telemedicine. This is a frequent confusing part of Project Echo. It's more telementoring. And so it's providers on both ends of the camera. There are no patients involved, and it really is a consulting and discussion among different providers. The benefits are many. Certainly there's benefits to the patients who can get good care close to home. There's increased capacity in providing this sort of model for different disease types, and that providers are now able to provide more specialty care locally. The community benefits because you maybe have reduced disparities in providing better care locally, and the system is improved because you've increased access to different types of specialty care. everybody shows this slide. You've seen this one before, but the inequity of cervical cancer seemed like a good place for us to use the Project ECHO model. Yes, the United States has low rates of cervical cancer, but there are pockets where the rates are higher, and one of those pockets is along the border with Mexico, the Rio Grande Valley, where the rates are about 30% higher than they are in the rest of the state, and Texas is sort of at the bottom of the list in terms of incidence of cervical cancer and pre-invasive disease. It's a poor population, as you might know. It's a very transient population, particularly now, and fewer than 10% of women in this region were receiving cervical cancer screening. And in addition, in the public system, there's a limited number of providers, including the fact that there were no providers performing some of the basic treatment services for pre-invasive disease. So we started a Project ECHO. We partnered with federally qualified health centers and providers serving the uninsured and the poorer populations in this region. We held video conferences every 2 weeks and generally had 20 to 25 providers, primarily nurses and physician's assistants, join. We discussed cases, we provided a brief didactic, we were all very engaged and we learned from each other. It's not a webinar, it's not our specialists sending knowledge one way. Everybody learns from each other, and we learned about the challenges of providing good care in some of these regions. We have been doing this now for almost 5 years. Like I said, about 20 to 25 people who participate in the clinics, and the feedback has been very good. And that is, we still have some of the same people 4 years later who are part of our Project ECHO group. But for cancer, ECHO is usually a part of a larger strategy. So provider capacity building is really an aim of the Project ECHO model. Some of the skills we need to teach for cancer involved surgery, et cetera. And so we provide also hands-on training for teaching providers how to better manage patients with pre-invasive disease and how to perform some of the diagnostic and therapeutic procedures that are required to best manage women with pre-invasive disease. We use Project ECHO not only in Texas, but also in parts of Africa, Central America, and South America, where the rates are very, very high. And the Project ECHO model has been adopted by many others. So the International Gynecologic Cancer Society now uses, as part of their training program, Project ECHO to hold virtual tumor boards in probably a dozen different regions around the world. It is part of a larger strategy to train physicians in countries where there is no training program for gynecologic oncology, but to create a program where they are able to provide cancer care for women with cervical and other gynecologic cancers. As part of our strategy, we also employ health system strengthening, and as was said earlier by the speakers, we engage as many people as we can to help strengthen the health system. That is everyone from the First Lady and the Ministries of Health to the academic centers and NGOs and other organizations. If we all work together, we'll be much more effective in reducing the burden of cervical cancer. So just back to Project ECHO and cervical cancer in the U.S., the American Academy of Pediatrics is using Project ECHO to help improve HPV vaccination rates in pediatric practices within their regions. We use it for cervical cancer prevention, not only in South Texas, but also in Cameroon and other countries in Africa, and it's a very big program in India as well. Project ECHO is used in improving treatment of cervical cancer, primarily through the International Gynecologic Cancer Society in multiple locations And we also use Project ECHO to improve services for palliative care, which is unfortunately a very big need in many, many regions. It's a way to move knowledge and not patients and not providers, and we've had a great deal of success and a lot of positive feedback in using this model, not only for cervical cancer prevention and treatment, but for several other cancers as well. Thank you, and if you're interested in learning more about Project ECHO, please visit our website, MD Anderson's Project ECHO website, or the University of New Mexico Project ECHO website. Appreciate it. Thank you.
Thank you, Ellen. That was very informative. Now we have a few minutes for Q&A. Perhaps we can start with this first question to you, Julie. How do we get the vaccine manufacturers to get Gardasil 9 globally, because that has a better coverage than the other 2 vaccines which are out there? Any thoughts on that?
So the aims, Shobha, of the global initiative to eliminate cervical cancer is to identify accelerators to improve uptake in each of those 3 areas of activity. So prevention with the vaccine, prevention with screening and early treatment, and treatment of invasive cancers. So the team is working with different partners across the UN and expert groups to identify accelerators. And of course, access to the HPV vaccine and affordability of the HPV vaccine is a key accelerator that WHO, Gavi, and UNICEF particularly are working on. And one of the exercises that they've taken over the course of the summer is to engage current manufacturers, but also those developing HPV vaccines and potentially also able to join the market in the next few years, to inform them about elimination, look to see how they might be able to increase their production and therefore increase the volume of doses available to the world. So I think at the moment what we're really looking at is making sure also that countries are ready, that they've got their plans worked out, their strategies for implementing vaccination, that they've got their staff ready in place and trained, they've got their community awareness materials ready to go, so that they can take advantage of this increase in production that hopefully will come as more manufacturers start to engage. Of course, the different types of vaccine are considered a challenge, but actually at the moment we want to get any vaccine out to many of these countries, and we need to see that the production times for manufacturers to respond will take a few years. And so in the meantime, we need to work to get countries ready to take advantage. We've seen in the past great impact of uptake and advocacy on the affordability of the HPV vaccine. If we recall a few years ago, we required 3 doses of the vaccine, and research has shown now that we can go down to 2 doses. Potentially on the horizon, we can go down to 1. That also helps both affordability and access. Gavi taking up the HPV vaccine has reduced the price. And we also have pooled procurement areas, such as in Latin America and the Caribbean, run by the Pan American Health Organization, that's helping pool procurement and also getting a reduced price for the vaccine. So we're looking to work on all fronts to reduce the price, increase the uptake, and I think that will also help then taking the more innovative vaccines to be more affordable for every country over time. As I said, this is a long-term game. We've got to talk about vaccinating all of our future generations. And so we've got a great opportunity to increase uptake of the best vaccines once they start to prove themselves, and also make those affordable. So it's very much a long-term view. The manufacturers are involved, and particularly Gavi, UNICEF and WHO are working very much on that as a key accelerator for the elimination initiative.
Thank you, Julie. Yes, as you mentioned, if we can get it down from 3 to 2 doses, which we have, from 2 to 1, that would be helpful. Also, to get any sort of a vaccine to start the elimination process would be very beneficial. Of course, none of us can forget that screening is here to stay for a long, long time. And I think the more we are able to introduce self-sampling, where women don't feel that they have to come to a doctor's office or a provider's office and get a pelvic exam, I think that would also help. And of course, to also remove the cold chain, which means refrigeration of the vaccine. That is a problem in many, many parts of the developing world that we kind of tend to overlook. So there are a lot of things that we have to take into consideration, but we have to start somewhere. And, I'm so glad that the WHO and Dr. Tedros in particular has taken on this initiative. And I hope that we will come together and move in the right direction. Thank you, Julie. The next question is for Ellen. And here is one question for you, Ellen. In regards to Project ECHO, how do you translate different communities with different resources, rural versus city, into a comprehensive program that is uniform between different settings to get comparative outcomes?
That's an excellent question. Each of your programs would really have to be, I think, evaluated independently, depending on what that particular program is. For Dr. Aurora, it was fairly easy. It was fairly uniform in the state of New Mexico and the treatment options for hepatitis C at that point. But cancer is not one disease, and resources available for cervical cancer prevention and treatment are very variable. I think we could do that within each country, but it's very hard, I think, to do that across very different environments. So that is a challenge to really looking at outcomes and effectiveness.
And as a follow-up question, Ellen, how do you think that we can close the gap in the United States itself? We have 13,000 cases of cervical cancer. There's just so many more diseases and cancer in both men and women that we are just beginning to scratch the surface and recognize. And I think it would be good to, bring on ECHO. I'm a huge fan of it because it's just not translated into cervical cancer and HPV vaccination, but to anything in the medical field and beyond. How do you think ECHO can be used in the United States to bridge the gap and to bring this down, the numbers of cases and deaths from cervical cancer and other HPV-related diseases in this country?
Yeah, being very... Not being terribly objective here, but I mean, our observation is that women know they need to be screened. I mean, education is part of this, but they know they have to be screened. We really need to improve access, and that requires real work. So you can't start a Project ECHO video conference and magically expect people to show up. It's really a model built on relationships and really shared goals and shared aims. And so we have to go out and really put boots on the ground and meet our colleagues out in FQHCs or areas where the rates are quite high, and have a face-to-face discussion and get them engaged in joining us in Project ECHO as one means to improve access and to improve care for women with pre-invasive disease, and also to improve screening rates. There are ways to do it, but it requires real work. And so ECHO is, like I said, one part of a larger strategy to do that. But there is no magic bullet, right? You have to get out there and you have to have discussions with your colleagues who are providing these services and work together to figure out how to have a broader reach and how to do a better job.
Yeah, you brought up a good point because, at least for cervical cancer, we have a screening, we have Pap tests, we have HPV DNA testing, we have other tests. But how about men? The rates of HPV-related cancers has surpassed cervical cancer in the United States just because for women, we have cervical cancer screening. But for men, there is no method to screen for it effectively, and there is very little awareness. And so that is the reason why the vaccination, if both boys and girls are vaccinated, it would be much more effective. The next question, perhaps I can take this, to increase vaccination rates. How about universities make it mandatory for HPV vaccination for incoming students? Well, that, school-based vaccinations, all are great ideas, and it is being done around the world in many countries. But in the United States, if you're speaking specifically about the US, it's not that easy. As you know, only 2 states have mandated the vaccine right now. About 29 states have, maybe some education about HPV, but there is a lot more that we can do state by state to raise awareness, both in men and women, and about and to people in all walks of life, like I discussed in my talk, and try to get the vaccination rates as high and as much as we can. Next question is on handouts. Well, if you go to the chat box, someone wanted to know where are all the handouts. I know Ellen has a handout, a PDF version of her presentation. Julie, I don't believe, has a handout. And for my presentation, actually, I put in a handout, which is also a PDF version of various slides that we have compiled that, hopefully anybody from any country, if you want to start an HPV Awareness Week, you're welcome to take that as a template and just plug in the numbers which is specific to your country and take it from there. So it's kind of a template that you can use. And there are also several other handouts that you will see in the chat box, and you will also get a link via email that you can access it down the road. So one more question, Ellen. It says, could has been used to train facilities providers on maintenance and repair of cryo machines. I think they're saying if ECHO can be used for these kinds of in-service and, how do you do this, or how do I get over the difficulty that I'm having in my program with certain equipment, et cetera.
Yeah, I'm not sure I would start an ECHO specifically for that, but we certainly have lots of challenges with the equipment in many of our low resource settings. But there, obviously there are many ways to handle those sorts of things. I would not necessarily suggest a project ECHO for equipment repair, but I suppose somebody could come up with something like that.
Yeah, and now we have thermocoagulators. Many are battery operated. They have rechargeable batteries. So, we are making progress so as to get away from these huge tanks that people have to be lugging from place to place. One has been in the developing part of the world and actually seen it, been there and done it, then that it's not as easy as it sounds. And there are a lot of barriers and challenges to it. One more question for Julie. I think that would be the last question. If somebody came and said, okay, Julie, here I am, ready to help you with the cervical cancer elimination initiative, what are the 3 most important things that you would need to make a running start with it?
Oh, that's a great question, Shobha. You mean I can have a magic wand? Obviously, what we need is all experts to come together and embrace the elimination story. There are a number of working groups, a part of the initiative, looking at some of the areas we've been talking about today, making sure we harness the direction that research is taking, coordinate our research efforts so that those results come in and can be fed into implementation and national plans as soon as possible. I think the magic wand would really be political support and funding for these initiatives, both from the perspective of international funders to make sure that development funding flows into this area so that the poorest countries can really start to catch up and build their health system response. And I would say really aligning our messages and get that message out to the public to really engage positively on health. And let's not just focus on the vaccine. As you said, the screening is so important. We want the latest technologies to be available in all countries. Unit Aid, a donor here, an agency here in Geneva, has called for proposals to help countries in the lowest income settings to scale up their screening, to use the HPV DNA test, which is much more specific and can be integrated with self-sampling that you mentioned earlier, really making the services close to what women need, avoiding that horrible speculum that none of us would like to have, and making a service that we want to take advantage of. So political will that is really committed, funding to make it happen, and expertise all flowing in the right direction.
Thank you, Julie. That was very informative. Thank you, Ellen. I hope, I really want to thank the audience for showing so much of enthusiasm. I'm so sorry we have to cut short our Q&A session in the interest of time. This brings us to the end of today's webinar. Please visit Us versus HPV for details on accessing handouts and recordings of the webinar. Our colleagues will be here same time tomorrow, and the topic is on HPV-related non-gynecologic diseases and cancers. Thank you for your participation. We look forward to you joining us in our HPV awareness campaign. Bye.